Welcome to Podcast on TechNation. This is a series of podcasts focused specifically on the biomedical and HTM industry. Episodes will be added monthly. Listening to each episode is eligible for one CE credit from the ACI. At the conclusion of this episode, you will be able to access a survey that will appear under this episode's title. You will be able to download your certificate once you submit the survey. Before we begin today's podcast, I'd like to invite you to our Spring MD Expo. We will be in Las Vegas April 7th through 9th, so please visit mdexposhow.com for event details and registration information. Podcast on TechNation would like to thank our sponsor, Multimedical Systems. When you're in the business of protecting the health of patients, you don't have time for malfunctioning medical equipment or dull surgical instruments. You need a reliable partner that can provide expert repair and planned maintenance to ensure you have patient-ready equipment that meets or exceeds OEM guidelines and regulatory requirements. Multi-Medical Systems provides these crucial elements and others such as on-demand temporary biomedical staffing, endoscopy and surgical repairs, infusion pump preventative maintenance teams, and equipment sales. For more information, visit multimedicalsystems.com. In today's episode, we are joined by Almetha Ford and J.C. Newell as they discuss cybersecurity and the key defense to patient safety with Sherelle Sandrini. The title of today's podcast is HTM and Cybersecurity: Who Owns What?
Welcome back to HTM Insider. Every episode, I'm so excited to bring on new guests and new topics, and today is like no other. If we haven't met before, my name is Sherelle. I'm with Multi-Medical Systems, MMS, and today we'll be talking about the HTM industry as a whole and how you, HTM, are the key to defense for patient safety. So I've got some amazing guests on today who really don't need any introductions because they are, rock stars out there. First, I want to introduce my friend J.C. Newell. We've been friends for quite a while now, and I just love her spunk and her tenacity. And we're going to talk about not only HTM, but how can you affect change and where the industry is going. So, J.C., why don't you introduce yourself?
Hi, all. I am J.C. Newell. I am currently working as a senior cybersecurity project manager with Kaiser Permanente, but I'm also the owner of Newell Recruiting and Consulting, LLC. And I am one of the founders of IHTM, Integrated Healthcare Technology Management. And our goal is to bring all of HTM together in the same box. Let's collaborate, talk, network, get it in. Thank you for letting me be here.
I love it. And Almetha, let's hear about you.
Hi, I'm Almetha Ford. I've been in biomed since, started in 1996. Went from biomed tech director all the way up. Got some degrees behind me in cybersecurity and stuff, and I've been working in that field for almost 10 years. I am also co-member and founder of IHTM, and my focus has been very directed on medical device cybersecurity and integration. And right now I'm working as a consultant with Tata Consultancy, and I work with manufacturers on helping them develop their programs and stuff, because now with FDA regulations, they must do additional things on top of what they already do and focus on cybersecurity, which they didn't have to focus on before now. So there's a lot of things and changes coming down the pike that we all need to be aware of.
Oh, I agree. And I love that word integration. It means so many things, right? In so many different applications. So let's talk about that word, and you guys can kind of go back and forth. But integration. So biomed, you used to have a wrench, some screwdrivers, you'd go fix the machine. But gosh, now we're saying integration is bringing a lot of other, nuances and regulations, and how do we keep up with all this? So let's talk about what is a biomed and where is a biomed going? So ladies, which one wants to take that and start off?
All right. So in my world, we have biomedical equipment technicians. You have biomedical engineers. You have clinical engineers, and a lot of people just roll them all up into one. These are the people that take care of medical devices, but that's not necessarily so. Biomedical equipment technicians are out there and they're created just to focus on medical devices in the repair and maintenance, calibration, and support. Whereas a biomedical engineer, they know how to build a medical device. They know how to structure a medical device. They are into the compliance and regulatory of that device. And a clinical engineer is all about the clinical applications of that device, as well as how to build and maintain that device. Would you agree, Almetha, or do we need to add
They
more to that?
also deal with management skills, policies, procedures, standards, stuff like that. More focused on compliances and other areas in the hospital where the environment of care is affected and where they have their questions, where maybe the biomed tech does not really go to. So the clinical engineer helps more in the managerial and engineering functionality of what encompasses the whole of that whole area that people don't even really know exists.
Right.
Yeah, yeah. And the funny thing about all of this is that for years, you had departments, clinical engineering, the biomedical engineering department, the biomedical equipment technology department, the BMET department. And it was wonderful that Amy years ago said, okay, let's just come up with one name for it. And we all agreed on healthcare technology management. So then the HTM technician was born, all encompassing, and it gives us one name that we can stand behind and say, this is who we are.
And I want to applaud both of you because, as we know, this is an excellent career field for women.
Oh
And
my gosh.
hopefully today you might inspire some young people, especially young women, to get into the industry. I think women excel in this industry, not to say that males don't, but you are not what you see when you walk in a shop normally. You need to be seen, you need to be heard, and I'm so honored to have both of you on today.
Thank you.
Yeah. So that with that said, I want to know, because JC, you've been doing this a long time too, and you started in the military, I know.
Yes.
So let's just narrow it down a little bit to the last 10 years, because I've been in the field about 12 years now, and I've seen the jump. I mean, now, even in our own company, we were on triplicate forms, and now we're automated completely. We had a CMMS program, but some of the stuff we did over here, now everything is encompassed and tracked through our ISO certification and our CMMS program, right?
Yes, definitely.
So, wow, think about 10 years ago. What have you guys seen as the biggest change in technology and integration?
For me, the biggest change to me is the amount of women coming into the field. It has been explosive. We kind of turned to this STEM technology thing and put it out there. I love the fact that women are seeing this as challenge accepted, and they're jumping in with their male counterparts, and they're eager and hungry to learn. They are finding some difficulties, however, in their male counterparts, taking them under their wings to teach. But they need to understand that they're coming with a new perspective. They want to be additive. They want to be that additional strength for the department. So this comes as something that a lot of departments and a lot of their male counterparts see them as, well, what can they do? You'll be surprised. They're going to surprise you. They will eat up everything that you're doing and show you better ways of doing it. I think a woman is the ultimate multitasker. And people say, oh, there's no such thing as multitasking. Well, let me tell you, if she can get up in the morning, take care of the kids, feed the hubby, make sure everybody's off to school, and then get her work done at work, she's all over it.
Yep. I think women in general are problem solvers.
Yes, definitely. Every day. Every day.
So what about you, Amita? Let's talk about what you've seen in the last 10
Oh
years.
boy. So it's been a little bit, and let me go and say I agree with the perspective with women. The also thing that helps with being a female in the biomed arena is we deal with nurses. The communication between a female technician and nurse is like almost like the communication between, it's female to female to female to male. So what a nurse says, we hear differently than sometimes our male counterpart, or gain insight from, or they're more comfortable sometimes. So just like where a man would talk to another man. So I'm just gonna say for that piece, all the gender differences. But the things that has really changed healthcare, forced healthcare to change, was when, I don't know if you guys remember, when meaningful use was being forced into the healthcare, forcing, kind of pushing, because before, when EMRs were presented, I had nurses and managers saying we'll never get EMRs because they're too expensive. But when the federal government said, we're going to kind of push you to do that because we're going to give you incentives using meaningful use to inspire and encourage and kind of get you to do those electronic medical records. Once those got in place, now everything is becoming more integrated. Everything is now being put in those medical records, which there's a whole nother end to what that's trying to do with the CDC and everything else. If you really look at what's going on and what needs to happen for diseases and tracking and um, them doing their statistics and stuff like that, it's going to become more automated. And the way to do that is going the way that we're going. So this has been stuff that's been in motion for 15, well, more than 15 years, but we've been seeing it within the past 10 years. So now we have all these medical devices, thermometers, glucometers, and pumps and stuff that were never integrated before, that were patient monitors were on isolated networks, and now they're all going into, those servers and stuff are now being integrated into the EMR. The packs, the images where people used to have to carry their images. Remember, you used to have the
Yep.
Yes,
You better go
yes.
check it out.
now you can just call and say, hey, can you send my CT to Dr. A, B, and C? So now with all this integration is coming in the past 10, 15 years, that's changed how we have to look at medical devices. If you look at stuff, medical devices used to have a history of 20 years. Pumps were 18 years old, your CT would be 20 years old and stuff. So people would have all this stuff. Now, with the turnover of software lifespans, life cycle, you can't do that. You can't, it'll show up with the scan of, I've had where a scan some years ago had NT. And to change that CT, that IR room, CT room, you would have to replace it, which means 30 days that whole system would be offline. Well, if that's your only system, how does that go offline? You can't. So how do you make those adjustments, satisfy the mitigating points so you stay safe, even though there's an exterior edge perimeter that IT is putting for firewall protection, edge firewall protection? As you can see through all the breaks, all the breaches that you may not, and many that have not been reported until they were forced to be reported, you're getting through those edge. So the only thing that we can do is now we need to think about defense and layers, putting defenses up. And so those are things that we never really focused on as biomed. We focused on safety. What's safe for safety, how's it working? Is the nurse know and trained? Because we work closely with our nursing staff. Now we need to say, okay, cybersecurity, does our database even accept those data points that we need to search and have? You know what I mean? What does it mean as a biomed tech? Because back in the day, it was from, I got my machine into the wall is us. Anything past the wall is you. But just like your body has an arm, you need to look at the whole system. You can't just look at the arm and treat just the arm. You have to treat the whole system. So you need to understand that whole system. So you need to know that there's blood going through your veins to your heart, your lungs is oxygenating. Well, you need to do that for medical devices, because when there's a problem or something goes down, it's just not one part of it. It's not just affecting one part of it. It's affecting the system. And we'll get in and out and access that system. So I'll just stop right there. Sorry.
Yeah, no, that's what I think is very important. And And to the public doesn't really understand this. They expect the machines to work, and really, they go into the hospital, they think the nurses and they take care of them. Nobody has any idea all these layers of safety that you're discussing. Yeah. I'll share a story with you is that my husband went in for surgery, and the first time it didn't happen for various reasons. We go in there the next time, and the surgeon says, well, we're going to have to wait. They're trying to get the device that I need to use for the surgery. There's an issue with it, and they're trying to take care of it. And I'm like, what kind of issue? He's like, well, I don't know, but they're just trying to check it in, and they're not getting it checked in. I said, what OR room are we in? I'm sitting there with my husband. He says 5. I dial my friends down in clinical engineering that I know, Angie and Steve. I text them, hi guys, my husband's going in for surgery in OR 5. What's the problem? And it was the device brought in by a vendor, so layer of safety, right? Brought in by a vendor that does a cold ablation, right, in his back, and it had not been PM'd for over a year.
Oh, wow.
And so the great and powerful safety people that HTM is, they said, you can't bring that in.
Right.
And then they told me that the surgeon comes back, and I said, no, we can't do the surgery. They go, well, they're trying to call Florida because they said it was PM'd. I said, sir, it's not PM'd. I said, if it was PM'd, it'd have a proper sticker on it. And this man turns to me and looks at my husband. He goes, it's what she does. So we're not doing surgery today. When the machine has been PM'd and it's properly brought back by the vendor and checked in successfully by a biomed, then we can have the surgery. Right? But I wouldn't have known that. I wouldn't have known that. The average person going in there to get surgery or in a hospital room doesn't understand these layers of safety and how defensive y'all are about patient safety.
Yes. And what I love about our field is that all of I can't speak for every biomed tech out there, but the majority of us, when we go into a hospital and we're working on equipment, we treat it as if our loved one is going to be on it. And for us, it is so crucial that we have a mentality of, it's not on my watch. This device will not go down on my watch. What can I do to make sure that this device is safe for this patient on my watch? And in saying that, it correlates to what Almetha was saying, the whole system, because even though we're there at the patient level, looking at the device and saying, hey, is there a PM sticker on it? We also have to look at, hey, is this thing safe from a cybersecurity perspective? Can this device be hacked? Are we putting this patient in more danger when they get put on an infusion pump if somebody can get in it and change the dosage? So for us, when we look at it as a not on my watch thing, we have to look at those things that we can physically do something about, and those things that there is a presumption of. We have to put up those, like Almetha said, those layers of defense so that we can protect the entire system, not just the machine, just at the patient, because it's way more than that.
Way more than that. And we've seen so much of it recently, right? With some cybersecurity attacks at big health systems. Yes. And nobody wants their information out there to who knows who and where, and because there's a lot of information in those records.
Oh, definitely. Definitely. When you're sitting there looking at the fact that if someone got into a patient record and knowing their social security number and their addresses and things, it turns into a very large liability for any health system.
So I would say patient records is one thing, but when there's a potential patient fatality associated. So there's a case, and I haven't seen where it's closed. I'm waiting to see what that conclusion is, where there was a cyber hack. They got into the hospital. The systems were not as layered as maybe they could have been. They were able to get to the nurse call. They were able to get into the networking for the patient, I believe the fetal monitoring. So they had the bedside, but they didn't have the central. So a lot of that integrated infrastructure may have been affected because, all that information is not going to be given. But from what was written, that's what it seems like. So now you got that affects staffing, because now you got to have staff watching each one of those patients in bed, where before you had what, the nurse to patient ratio maybe be 2 to 1, 3 patients to 1, where now you got mamas having babies, and what does that need to look like, a 1-to-1 or something? Can you call the doctor? Are you able to print out the strips or get the strips that are going to send you alerts and alarms to notify you? So that's why we need to be cognizant of what the effect is on how we have our devices on the network. Because the difference is, here's the difference. IT knows networking, they know computers and everything else, but many of them struggle with, how come we can't patch now? They don't understand what the difference is between a medical device and a business device, what 510K requirements are, what FDA regulations and restrictions are for dealing with medical devices, how you can't patch unless it's validated, or even put anything on the system as for cybersecurity, because now you're violating that system. And if something goes wrong with that device, it's not on the manufacturer because you just altered it. It's on hospital. It's on you, because that's not what you're supposed to do.
Yeah.
Right.
So let me ask you ladies this. So I've been hearing that patches need to be completed, but yet the cost to make that happen, or the staff to make that happen, just aren't available. And they're trying to find ways around to get these patches done and create this budget that wasn't in the budget before, find this money. Do you find that that's what's going on out there, and why maybe people are delaying patches and upgrades?
All right. So I would say one of the biggest problems we have is the IT to biomed collaboration, because many patches can be given to the facility from the vendor. And if it's a tested and tried patch, IT gets involved. And if they get involved and they agree to work with the biomed team to test that patch on a device and see if the device can take it, then it's definitely one where the collaboration between IT and biomed, and they get together and they determine, hey, these are devices that need the patch. Technicians have to do PMs anyway. They have to do repairs anyway. So why not just integrate that patch as part of your PM or that update? Not only are you saving the hospital money from having to call a vendor out to patch all of your devices, but you've breeded a stronger collaboration and relationship between your IT and biomed departments.
So what if your biomed manager feels the other way back, that they don't want to work with IT, and that IT patching is their job, not mine?
Right. And that has been a systematic problem with our field for years. It comes into, well, that's not my job, that's their job. Like Almetha was saying, to the wall is and to the device, towards the device is biomed. Behind the wall, that's someone else, whether it be facilities and IT. And we have to move past that to see if we can do more, because now the dangers and securing of a medical device is different. It's not just if the device fails on a patient. It's not just if they have the wrong syringe to the PCA pump or something like that. Now it's bigger. Was the device hacked? How can a biomed tell if it was hacked? If there's a hacking going on right now, if the device is being infiltrated, how can we tell? And that comes with more education, more knowledge, and more collaboration. And this brings me back, Sorrel, to why HTM exists. We created this site to bring us all together so that we can collaborate more, learn from each other, because for a lot, IT feels as if biomed is only break fix, and we're way more than break fix. Biomed feels as if IT can't do any more than sitting behind a desk and being desktop support, and they do way more than that. But together, they're invincible. Together, they strongly take care of patients. if they come to a place where they understand where each other are. Let's get together. Let's learn. Let's learn what each other does. Let's put that together and protect our patients, protect our hospitals, if that makes sense.
Yeah, that makes a lot of sense.
So I come also from another aspect, and that's what makes HTM so great, because each of us come with our own aspect of the same struggles and how we look at it. So there is a biomed and IT collaboration that really needs to happen. Healthcare, what really affects that is healthcare organizations and manufacturers. So last year, December 29th, the federal government has this omnibus bill that they pass. Things that they added in there, which finally gave some teeth and made some partnership requirements, was the medical device portion of it, where now they have to have a scheduled patch and release, where before they either did it or they didn't, and it was always hanging in the road. They have to have a timeline for all their new products. As of October, they have to have vulnerability management program in place, a patching process and timeline in place. They also have to have incident response. How many times have you sent out and asked about when there's an incident or something like that with the manufacturer? It could be cybersecurity, and you're waiting and you're waiting and you're waiting. I've waited 6 months for a response and stuff. The other thing that I find that is extremely interesting. Now, you don't just have accessories. Did you know that when you have your medical devices and stuff, your systems integrated and put in your your CT radiology devices and stuff, they give you a firewall, but your firewall is an accessory. Well, with accessories, they don't even worry about those. So now anything sent for a cybersecurity component for your medical device is considered part of that system. So what happens when you have obsolete firewalls on your systems, because your systems are 15, 20 years old? Who's handling that? The other part of that is how many people, how many healthcare systems now incorporate up-to-date cybersecurity requirements, components in their contracts, in their service agreements? Most of them don't. I mean,
and how many actually know and understand it, especially rural health, right? Critical
right.
access
So
hospitals. We're providing vital care to people that are not in the big cities. They don't, how are they going to do that?
Don't say in our service agreement patches are provided. In our service agreement, you have show me the process for your incident response for when we have an incident. So we're not chasing the field engineer and stuff. We have a straight response because there's a timeline we have to go through to do that. Who is the person that we need to say, hey, we're getting these vulnerabilities on our systems and stuff. I can't just send you an email for all these stuff and over and over and over again. What is the accountability of that? Are you putting those things in your contracts? And in many cases, they're non-existent. In a lot of, if you go and look at your contracts and your purchases, so that is something that needs to be the marriage between manufacturer and healthcare organizations. I think if more of them start adding that and demanding that, it will help be the voice of the customer to the manufacturer and kind of dictate itself to where there's a demand, they will do it.
Yeah, and that's why I think biomed should be more involved in purchase services as well.
Yes, absolutely. And you know what? For the life of me, I kind of see it as more often than not, you have a biomed tech or a biomed team just says, they're just waiting for them to tell them if something is on the dot, or they don't have a relationship with supply chain where they're saying, hey, we need to get more involved on what can be purchased and what cannot. But this is interesting too. There are a lot of facilities and departments that don't have a seat at the table for their biomed tech. Your biomed tech is integral to your capital equipment planning. What you're getting ready to buy, they have a bigger job than just if it's you bring it in, we onboard it, we put it in the CMMS, and then we do a PM on it. No, we can help you determine whether or not that device is safe enough to be in your hospital before you purchase it. We can check FDA adverse events to find out how many patients were hurt or killed for that device before you buy it. We can also check other facilities to see how much it costs them to repair that device over and over again. So to see, is it more expensive to repair it than it is to buy it? But we could also give alternatives for devices so you have more than one to choose. You have vendors go into hospitals, they tell the doctors and the nurses about these devices, and they're like, ooh, I want one, I want one. But let biomed be your arm. Let HTM be your arm. Let us look into that advice you want to buy. Let us tell you whether or not it's worth buying. We have that skill set. And that's what we also bring to the table to help support the facility. But a lot of hospitals don't use us that way.
So I think part of that is too because people don't really understand. I don't think that they understand what it takes for people to become biomeds. They're either military trained, which means years. They are associate's degree trained, which is years, or they are bachelor's degree or master's degree trained. Very, very extremely few percentage just come off the street saying, hey, I can touch a medical device. There are years of training and then years of experience that goes into you becoming a biomed tech. You can't just take a 6-month training class and just say you're a biomed. It takes time. You could be an apprentice or whatever else to start moving up to do more because they're not going to give you higher end stuff until they tested your competency and make sure that you know it. As opposed to a person, it's easier for me to train a person in biomed in 6 months to understand and work with IT devices than it is for me to get an IT person to learn biomed. To be a decent biomed with some general overall experience is, to me, a minimum of 5 years. Not only do you need education, you got to come in to the hospital. You got to go from thermometers to pumps, infusion pumps, bedside monitors, telemetry monitors, every single there. We have to know general functionality. We have to work with the field engineers. We have and the manufacturers. We have to read the manuals, service and user, because we're also training the staff. So it's easier and more beneficial if I get a biomed person and teach them IT, because then they're learning networking. They're networking, servers, computers, and most of them already know computers because they're dealing with patient monitoring and stuff and other stuff that's connected. So I think there's a confusion on the knowledge skill set of what HTM biomed clinical engineers bring to the table. I think if maybe some people had a day in a life, they would be surprised.
Yep, I agree. And it's really a professional career space.
Yes.
It's not a technical school, right?
Yeah.
It has a lot of technical components to it, but this is a professional career space, and there's a lot of opportunities to grow and to increase your education on your own. So if you're talking to a young biomed today, a 5-year biomed, what are some of words of wisdom that you can throw at them and say, why are you just staying here when you can go here? When you see it in somebody, what's the skill sets they can start looking for?
Oh, so when it comes down to biomeds that have been in for 5 years, it's about the grind. Be hungry. Go out and shadow everybody, eat it up. Go and learn as much as you can learn. But after that, take yourself to the next level. Go and get your IT certifications. CompTIA Plus, Security Plus, anything that they can get there. There are a lot of programs that offer free training, free certifications. Get it. Add to your skill set. When it comes down to the education, an associate's degree is really all you need in our field. If you want to go for more education than that, go and get a business degree so you can learn management, because that's your next step. You need to be focused on, once you hit 5 years, you're ready to step into the zone to where you're ready for more responsibility, ready to do more. You're ready to go and pick a modality. At year 4, you should be choosing your modality. Do I want to be an imaging specialist? Do I want to be ultrasound? Do I want to be anesthesia? Do I just want to be a general biomed and work on everything? So, but in all of that, My favorite words of wisdom are, sometimes you have to take a step back to move forward. Sometimes you have to take a job that pays you less, that gives you more capability. If you are going to another position and they want to pay you less, but they're going to teach you imaging for free, take it.
Mm-hmm. What about you,
I have
Almetha?
two. So one of them is, don't be afraid to travel. Opportunities are not always next door. And it benefits you to explore. I've been to Alaska, I've been to South Carolina, I've been to I said South Carolina, different places. Yes, I've been all over
New
the place,
Jersey.
Philly. So I,
She's remembering
and
where you've
that's
been.
a broad,
Yes. She's
I
been all
have.
over.
It's been giving me such a broad experience with different companies to learn skill sets, different locations in hospitals and stuff like that to see what's common and what's different amongst them. So don't be afraid to make those moves. All for you. And those are your learning lessons and learning opportunities to help you move up. The other thing I would say is what one of the points that Jules stated is be hungry. If you got field engineers out there, don't just let them come in and do the repairs and do stuff with the system. I'd be right with them. I'd be seeing what they're doing, learning what they're doing. If there's a network, I'd learn that network, what APs are connected. I'd be drawing network diagrams and stuff. I'd be ahead of the game with all that, knowing that, because now when people have questions, who are they going to come to? They're going to come to, because I have it and they know I can do that and do the skill set, and then they'll be more reliant on me, which helped me move up. The other thing I would say is don't be afraid of those opportunities. So with biomed, you're doing installs. You can help with project management piece of it. Work with that project manager. Learn project management so you can then be part of those installs. Manage those installs. Have more control and influence over those installs. So and get your project management certification.
Okay, so this is a first for HTM Insider. This conversation is so much fun. I know it's kind of ending kind of different than usual, but this is going to be part one of two parts of the conversation with JC and Almetha. So stay tuned. Again, you still get a CE credit if you listen through TechNation of this episode as well as the next episode. Check us out, follow us, connect with us on LinkedIn, Facebook, Instagram, all those things. And we look forward to seeing you next time on HTM Insider.
Thank you for a great presentation. If you enjoyed today's episode, you might enjoy our ongoing webinar series, Webinar Wednesday. You can find a calendar of upcoming live webinars as well as an archive of on-demand webinars at webinarwednesday.live. To obtain your certificate for 1 CE credit from the ACI, please remember to complete and submit the survey located below the podcast title. If you have any questions, you can reach us at webinar@mdpublishing.com.